And now I would request the chairpersons to give any comments on the presentation by the speakers and the panel discussion, if you have to contribute anything.
I thought that what should I contribute at the end? So I thought that maybe many of the audience may not be knowing some major timelines in relation to chronic kidney disease. So I wanted to share some of the timeline. I think it might be of interest. So CKD was never a major issue in 90s. From in 2005 and 2008, first time two national conferences were done for prevention of chronic kidney disease. Then in 2005, first study of community-based study of prevalence of chronic kidney disease was done from our hospital, although that study, I must admit, has a few lacunae also. 2006 Indian chronic kidney disease registry was made, and then after 5-6 years we had a major publication out of the chronic kidney disease registry. 2008 National Organ Transplant Program was launched, although it's not to do with, ultimately it's related to end-stage kidney disease. Since 2009, chronic kidney disease of unknown origin in Uddanam in Andhra Pradesh is going on. But still, say 11 years has passed, we still have got controversy of etiology of CKD-U in that area, as well as many other areas has also been found out where so-called chronic kidney disease is of unknown origin is being is questioned. You all must be knowing global burden of kidney disease, global burden of disease, which is handled from Seattle, USA, and every year it is data of global burden of diseases being published. Till 2015, India was not part of global burden of disease, but 2015 it started to be part, and one component of global burden of disease, chronic kidney disease, was also initiated. And we contributed, many of our colleagues contributed to chronic kidney disease, global burden of disease India component. And the major paper published in Lancet, Nation Within the Nation, has had a component of chronic kidney disease. So these are the few component or timeline with related to chronic kidney disease. And the last one is that we just completed in 2019 late a major multicentric study to find out prevalence of chronic kidney disease funded by ICMR from 7 cities. One of Dr. Burman is also part of that. And we are going to have a big enroll from 7 cities. So these are, I thought, some of the timeline which the younger colleague may not be knowing and will be of interest to them.
Thank you, Dr. Sanjay. This is indeed a wonderful contribution by you. And there has been important landmarks, many of which you are a part of, sitting in Delhi, the Ministry of Health and all that. And it's good to remind. Now, Dr. Mehul, would you like to comment on developments in the area of genetics? Of course, it was in the context of CACUT, but maybe you can comment on other aspects of CKD versus genetics, if you want to say something.
Yes, sir. Identify and hopefully another more insight into the genetic etiology of CACUT. That's what I would like to say.
Actually, when I was listening to Dr. Anu Vasudevan, even in CACUT, I thought it's more of a field of urologists, but for nephrologists, I think it was really a wonderful job done. And now, Dr. Manisha, I think you already partly covered what Dr. Amit was saying. Do you have something to say on the this aspect or any other things?
So thank you. It was a wonderful session, Dr. Gupta, and thanks to all the speakers. I learned a lot today. So just about the cactuses, identification of cactus also is natal. In some countries, there is a policy of doing postnatal screening with ultrasound for all the newborn babies, especially in Japan and China. And that way, some of the cases of cactus are picked up, like solitary kidney or hydronephrosis, which is otherwise not. The second aspect, when we diagnose a cactus, how to do a genetic analysis apart from the other imaging, what has been explained. That part has been covered beautifully by Dr. Anil. He has shown that it's open doing a genetic analysis for then which type to do, whether to do, a panel only or a whole exome sequencing, because panel again would miss, other mutations. So that was wonderfully done by Anil. But in our practice, many times I feel that cactus is missed, it's not picked up. So that was the comment on that cactus talk. And it was an excellent talk. And coming to the Amit has done a wonderful one. We know that anemia starts right from GFR, and it's very common in non-dialysis as well as of the causes of anemia. We should not miss out in our country on iron deficiency anemia, which is very, very common. We should know the markers of iron deficiency. We should know whether it's an absolute iron deficiency or a functional iron deficiency. Dr. Amit has explained to us the role of hepcidin as well. The ESAs, they do not have any much effect on hepcidin, but now we have reduced the level of hepcidin and made the iron available for erythrocytes. Dr. Amit has also told there are many new preparations of oral iron, and all of us should know what is the elemental iron contained in all these preparations and what's the bioavailability of iron in each of the oral irons. It's no point in just writing persolate and not knowing what it contains. Similarly, IV iron, we all know the recent trials have shown, the pivotal trial has the anemia